Bowel obstructions are the result of an interruption of the normal functioning of the intestines. This interruption causes an inability of the normal forward flow of contents of the intestinal tract, either in the small or large bowels. There are two types of bowel obstructions, mechanical or functional obstructions. While all causes of bowel obstructions can happen in both the large and small intestines, the most common cause of large bowel obstructions are caused by neoplasms, whereas the most commonly seen small bowel obstructions are a result of adhesions formed from prior surgeries or injury. Mechanical obstructions are a result of physical blockage in either of the intestines, blocking the normal movement of intestinal contents, whereas pseudo-obstructions, also known as functional obstructions, as the name suggests, is where there is no physical obstruction in the bowel, but is usually caused by a problem of nerves or muscles. Mechanical obstructions are usually a result of adhesions, tumours, hernia, volvices, or intussusceptions. Pseudo-obstructions are classified into three groups: myopathy, where the muscles in the intestinal tract don't contract as normal and they are no longer pushing the contents through the bowel; neuropathy, where there is no intestinal innervation to the small muscles of the bowel, leading to an obstruction. There is also Hirschsprung disease, which is a congenital disorder of the colon, where certain nerve cells are missing, and the lack of these cells inhibit the ability of the intestines to push through its contents through the tract and causes obstructions. In both mechanical and functional obstruction, fluids, electrolytes, and swallowed air builds at the site of the obstruction. This accumulation of fluids and air and electrolyte promotes bacterial growth, and if it's allowed to continue to build, it leads to an overgrowth of bacteria. This overgrowth increases gas production, which in turn only further worsens the distension of the bowels. If the obstruction is left untreated, this process of bacterial growth and gas production gradually continues until the intestines lose its absorptive ability and excess fluid leaks into the lumen of the bowels, exaggerating this distension. Vomiting is a symptom of bowel obstructions and happens quicker the higher in the tract the obstruction is. But vomiting only worsens the electrolyte imbalance and dehydration that is already happening in the body. The buildup of bacteria can also get to a point where it moves into the bloodstream and can lead to the patient going septic, which can result in a fatal outcome. If the obstruction is continued to be left unresolved, the interluminal pressure rises and it can cause vascular compromise as the blood vessels around are being compressed on. As this pressure against the vascular system continues, blood flow is being diminished. This will eventually compromise the blood supply to the bowel, first leading to strangulation of the bowels, then necrosis, and finally perforation.
Symptomology for bowel obstructions can differ slightly depending on whether it is a large or small obstruction. Symptomology also differs amongst individuals, the age of the patient, and depending on how far along the bowel obstruction is. Bowel obstructions in the large bowel include symptoms of abdominal pain, distension, and cramping similar to colic, nausea, vomiting, and diarrhea. Feelings of colic is indicative of the bowel increasing motility in an effort to overcome obstruction. Constipation and anorexia also are indicative symptoms of a bowel obstruction. Children and infants will also likely experience the same symptoms as adults, with the addition of nonverbal symptoms of fever, rectal bleeding, lethargy, bilious vomiting, and firm distended abdomen, by typically drawing their knees up to their chest and present as firm, stiff, tense, and restless in their aim to guard their abdomen. According to Nijgen and Holland, 2021, the development of lethargy, persistent and constant abdominal pain and distension indicates late signs of a bowel obstruction. Symptomology of a small bowel obstruction include the same symptoms as a large bowel obstruction, with the presence of malaise, dehydration, and severe constipation, with the inability of any stool or gas to pass through in the case of a complete obstruction. Additionally, both small and large bowel obstructions can have obscured, weakened, or absent bowel sounds on auscultation, depending on the cause and location of obstruction. Vital sign changes can also include hypotension, tachycardia, most likely due to pain, and fever in some cases.
Obstructions depends on what has caused the condition, with hospitalization generally required. To stabilize the condition, the following procedures may be undertaken. Urine output is monitored, fluids via an IV drip, pain relief and antiemetic medicines, nasogastric tube inserted through the nose to the stomach to relieve abdominal swelling, placement of a thin flexible catheter to drain urine from the bladder to be used for testing. A colonoscopy or sigmoidoscopy may be done along with an abdominal x-ray, and surgery may be discussed. Some surgeries include a laparoscopic, a expiratory laparotomy, and bowel resection. Antiemetic medications such as ondansetron can be administered to prevent nausea and vomiting. Nausea and vomiting can be due to the activation of vagal nerve fibers in the gastric wall and stimulation of the chemoreceptor trigger zone. Ondansetron is commonly used as this is a potent antiemetic that exhibits the effects via pathways where serotonin acts as a neurotransmitter. Bowel distension, secretions, and edema can cause a rapid onset of pain, and analgesic pain relief is an essential part in maintaining the patient's pain levels. Short-acting opioids such as morphine and fentanyl via IV address both the colicky and continuous aspects of bowel obstruction pain. The use of IV fluids is to maintain electrolyte and fluid management to prevent dehydration. If patients are unable to have oral intake for a prolonged time, consider IV parenteral nutrition for ongoing nutrient delivery. Antibiotics may be administered as well for the prevention of infection and sepsis. For partial obstruction treatment, if there is an obstruction where some food and fluids can still be passed through, there may not be any more further treatment after the patient has been stabilized. Doctors may recommend a low-fiber diet as it will be easier for the partially blocked intestine to process. It is recommended for the patients to go nil by mouth, which allows the gut to rest, allowing for the intestines to clear. However, if it does not clear on its own, surgery may be required to relieve the obstruction. For a complete obstruction treatment, if nothing can be passed through the intestines, surgery will be needed to relieve the blockage. The procedure will depend on what the cause is of the obstruction and which part of the intestine is affected. Surgery will involve removing the obstruction as well as any secretion of the intestine that has been damaged or died. In hospital settings, when interventions or surgeries to improve the obstruction are not possible, pharmacologic options are essential in maintaining the patient's management. Emotional support, clarification of goals of care, and transition to the outpatient setting can also assist the patient with their diagnosis.
Whilst the gold standard for pain management is analgesics, non-pharmacological management should not be overlooked and instead be used in conjunction with analgesics to increase the effects of pain management. It has been suggested that non-pharmacological management can be broadly divided into three categories: cognitive, behavioural, and physical, some of which are less feasible in the ambulance setting, however should not be overlooked wherever possible. Cognitive, the use of distraction techniques, talking to patients, listening to music, and guided meditation can help the brain become distracted from pain. It does this by shifting its attention to other places. Building quick rapport and providing reassurance for these patients is an essential management tool to help reduce anxiety, which can help lower the heart rate and sympathetic drive. Behavioural, relaxation can be looked at as the absence of tension within the body. By utilising relaxation techniques, it can help reduce blood pressure, heart rate, and oxygen consumption. Techniques that help patients slow their breathing down has been shown to help reduce physical pain intensity. However, the research suggests it is more likely that it is the distraction of focusing on slow breathing rather than the actual act of breathing that impacts on pain levels. Physical, applying heat or cold packs, massage, use of TENS machines, acupuncture, aim to reduce muscle tension and spasms. Where practically possible, allowing the patient to remain in a position of comfort is important, as this may help to keep them calmer, more relaxed, and help reduce their pain. Movement of patients, physical movement, and movement from the ambulance itself may cause further discomfort and pain, which our aim is to avoid. In the pre-hospital setting, extrication of patients in a seated or supine position should be aimed for rather than ambulating them, as this may help to reduce exacerbation of pain that can be caused from movement.
Important to look for and acknowledge the signs and symptoms of bowel obstruction as previously mentioned. Paramedics should take note of any guarding of the bowel region, as well as Murphy's sign while palpating the area gently, keeping an eye out for any hard pressures under the skin. Paramedics should question the patient about their last food intake, their last bowel movement, and gain the description, onset, and location of the pain, as well as asking about any other new bodily changes the patient may be presenting with, and if they find any relief from the pain in certain positions. In cases like this, it's imperative to gain the patient's past medical history and any current medications to remove any differential diagnosis. Pre-hospital management with regard to AV clinical practice guidelines includes treating the patient symptomatically. Where the patient is experiencing nausea, an antiemetic such as ondansetron or Stemtil should be considered. If the patient is experiencing a degree of pain, an analgesic should be given. Where the pain is moderate, paramedics should consider morphine or fentanyl IV. Where the pain is severe, ketamine iron should also be given, and if the pain is procedural or related to movement, mefloxiflurane can be considered. To treat early shock, paramedics can lift the patient's legs. This should only be done if the patient is comfortable in doing so and doesn't experience more pain. Additionally, IV fluids can be used for shock, dehydration, and lack of perfusion due to interluminal pressure and oedema. As always, rest and reassurance should be given, as well as O2 if indicated. Finally, transport to hospital is vital.